Mercer and UT. The perpetual student, he went back to school for his Master's of Public Health and Master's in Theology and Healthcare Mission, and is currently working on a lay ministry program. He's completed his fellowship in hospice and palliative medicine at the University in Louisville. He's been certified in family medicine, addiction medicine, preventative medicine, and hospice and palliative medicine. He's served as medical director for Hospice of Chattanooga for over 5 years and is now their chief medical officer. Please join me in welcoming Dr. Phelps.
Thank you. All right. Well, we're going to, my subtitle for this talk is Palliative Care, Helping Your Patients Write the Final Chapters. I believe Dr. Johnson, my more palliative care counterpart, is giving a talk in November. I call this kind of the undoctoring talk, because we're going to talk some about different ways of thinking about caring for patients towards the end of life. For the CME, regrettably, this is a statement of my poor finances. Nobody is bribing me, paying me honorariums, etc., for doing any of these, talking about this. Getting to what matters. If you haven't read this book, we give this to the medical students when they rotate with us. It's Being Mortal by Dr. Atul Gawande. And what it says is kind of an indictment of our current medical system. It says, I learned a lot of things in medical school, but mortality wasn't one of them. Our textbooks had almost nothing on aging or fragility or dying. And I highly recommend this book. When I get to the end, there's actually, because my mother was a librarian, there's a reading list at the end for you. But this is out of the Hastings Center for Bioethics Guidelines for Decisions for Life-Sustaining Treatment and Care Near the End of Life. And it says, patients will benefit from healthcare leaders who see end-of-life care as part of healthcare rather than a failure of healthcare. And it goes on to say, a few pages later, there are powerful incentives for hospitals to define care in terms of reimbursable treatment, interventions, and diagnostic testing, to prioritize quantity over quality, and to set lower value on services that are non-income generating. These incentives play a large role in shaping the delivery of end-of-life care. So I'm going to kind of talk a little bit about what not to do. This is a quote from back in the 1800s. I often thought it would be more important to instruct physicians how to behave in the cases of incurable disease, not so much tell them what to do as what not to do. And we're going to talk a little bit about that. Hippocrates also said that to try to treat a patient who is, quote, overmastered by their disease is a madness akin to insanity. So, first of all, I really don't appreciate it when I come in and I say, hey, I'm Dr. Phelps. I'm either with palliative care or hospice, depending on the badge I'm wearing. And they say, yes, they said there's nothing else we can do. And I go, yes, there is something else we can do. Cure sometimes, treat often, comfort always. And we sometimes tend to forget about that. So I'm going to use palliative care and hospice semi-interchangeably, but I wanted to draw a distinction. I did my fellowship in Louisville, which is the bourbon capital of the universe. So what I learned there is that all bourbon is whiskey, but not all whiskey is bourbon. So all hospice is palliative care, but not all palliative care is hospice. Hospice is an insurance benefit to get paid for people in the care at the end of life, usually the last 6 months. It's usually residential. The goal is to stay home and be comfortable when there is no other curative treatment available. It provides nurses' aides, physicians, medical equipment, hospital beds, wheelchairs, oxygen, medications related to the life-ending illness for comfort. We have chaplains, we have social workers, we provide bereavement services for patients after they pass away. That's what hospice pays for, and it's Medicare Part A, which pays for hospitals. Palliative care is Medicare Part B, which pays for physicians and can be engaged in life-threatening illnesses much earlier in acute care when curative treatment is still going on. My partner, Dr. Johnson, talks even about advanced illness management, and that's like several years before anticipated death. Palliative care is oftentimes thought of as the last 18 months down to 6 months, and then hospice, just to try to give you a framework to work within. But I will say that we need to remember all of us are dying. We all have a life-ending illness. It's called life. It's sexually transmitted. And we need to be cognizant of the fact that all of our birth certificates come with an invisible expiration date. So part of my talk today is about celebrating life. People say, oh, hospice, you work with people and they die. We work with people to celebrate their lives. We work with people to get them the best quality of life when suddenly the idea that I'm dying is no longer abstract, but very concrete. So we practice in a reductionistic system of medicine where we've got a heart doctor, a lung doctor, a bone doctor, a stomach doctor, and we divide patients into parts. And part of what the palliative care philosophy is seeing the person and reunifying that. So these are two slides from the Center for the Advancement of Palliative Care. One takes cancer and makes it a dancer to say that that's the patient sees themselves as a dancer, not a patient with cancer. Likewise, the mother comes out of chemotherapy. So they are reintegrating patients in their clinical care. So let me define palliative care as the Center for the Advancement of Palliative Care does. Specialized medical care for people with serious illness. Doesn't have to be life-ending. This type of care is focused on providing patients with relief from symptoms, pain, stress of serious illness, whatever the diagnosis. The goal is to improve quality of life for patient and family. Our unit of care is not the disease. It's not the patient. It's the patient and their family as they define it. It is provided by a team. We work with other doctors. I always tell patients when I come in for palliative care, I don't replace anybody. Nobody's losing their job. We're all going to continue. I'm just one extra layer. Palliative care is appropriate at any age and any stage of serious illness and can be provided along with curative treatment. So what do we do? I had to come up with an elevator conversation when I was in my fellowship, which was just a few years ago. I literally was on an elevator and somebody read my lab coat and it said palliative, and they couldn't pronounce palliative care, so after they stumbled for a minute, I corrected them. And they said, what does that do? And I said, well, we provide comfort for patients. And he said, oh, good, can you see my dad? He's in for hernia surgery. I said, well, he may have a stroke if I come in, so let me explain a little further. But we do comfort, pain, shortness of breath, nausea, constipation, spiritual angst, depression, whatever the patient suffers from. Communication is talking with the patient about diagnosis, prognosis, and treatment, looking at all the options. And then coordination is getting all members of the family, the patient, and the healthcare team all on the same page as to where we're trying to go. So, two mindsets. First is curative. As a family doctor, I practiced on the curative side. Primary goal is cure. Object of treatment is the disease. Symptoms are treated only as clues to the diagnosis, and primary value is placed on data such as labs and tests. The model tends to devalue the patient's subjective experience. Therapy is indicated if it eradicates disease or slows its progression. The patient's body is differentiated from their mind. The patient is viewed as a collection of parts. I already mentioned that. And death is the ultimate failure. Well, given my previous comment about life as a terminal illness, if you grade yourself on how many of your patients die, the short answer is 100%. The death rate in the United States is unchanged. It's 1 to 1. So you want to be looking at probably a different metric. I'm also a lot of fun at doctor parties because people say, oh, you should have seen that. Save this patient's life. And I just, you just postpone their death for a while. So palliative care, the goal is to relieve suffering. The object of treatment is the patient and their family. We treat distressing symptoms. We value their subjective experience. Therapy is indicated if it controls their symptoms. We look on the patient as a complex being with physical, emotional, social, and spiritual dimensions. I love working with chaplains. I've had a patient just a couple weeks ago. We were talking about their pain and how we seemed to be having a difficult time getting it under control. And the chaplain jumped in our interdisciplinary group and said, I think the pain is more spiritual than it is physical. Give me another week. We've been having a series of conversations, and sure enough, we came back for our next IDG, and the patient's pain was much better because they've been able to work through their spiritual issues. I mean, part of what we deal with are families that have been broken, and I was talking with somebody yesterday that I had a son that they hadn't talked to in 30 years. I said, well, do you want to before you go? And so I don't know. I'm thinking about it. So those kinds of things are frequently as important in the care as the medications that I may give. Enabling is a much better metric, I think. Enabling a patient to live fully and comfortably until he or she dies is a success. So everybody's entitled to some palliative care. We start off with quantity down at the lower level, and we're not getting much palliative care. And then the older you get and the more symptoms you have, the more palliative care, until eventually we go from a mix to hospice, which is just principally quality, and then death. And then even after death in hospice, the patient their family continues to get care. And I'm surprised oftentimes how much comfort patients get in knowing that somebody's going to be keeping an eye on their family. We have grief groups, we do grief counseling, we have grief managers. We did a children's grief camp a couple weeks ago. We have a teen grief camp coming up in 2 weeks. So we continue to follow the patients for a little over a year. So having been a hospital medical director for a number of years, I have learned that hospitals are not benign places. This says here, fill out this tag and put it on your toe as you're being admitted. And one of the things that we see coming into the hospital is, particularly in the elderly, is loss of activities of daily living. What is that? Dressing, bathing, toileting, etc. And when patients lose activities of daily living in the hospital, and a third of them over 70 and half of them over 85 do, 41% of those patients die in the following year. It's an indication of how frail and how weak they were to begin with. And 29% of the survivors still have loss of their ADL. So being in the hospital is not a benign thing to do. So when do we start thinking, gee, maybe we ought to do something different? These are palliative care triggers, and there are a bunch of different trigger tools out, and I've kind of consolidated them. The first one, would you be surprised if this patient died in 18 months or if you're dealing with children before adulthood? And if the answer is no, then you might be wanting to think about introducing the palliative care concept. 6 months for hospice. I talk with the residents most Friday afternoons, or at least I meet with them, and we'll have the conversation that goes like, oh, Mrs. Smith, she's back from the nursing home. There's a round of kind of groan. She's back again. She's in the hospital with this. Where's she going? Back to the nursing home. When those patients are bouncing back and forth like that, that's a time to start having that conversation. Patients will keep coming back seeking aggressive care until they know that their care is going to be unsuccessful and they are on that final slippery slope towards the end. Other things to think about: complex care requirements, functional dependency, getting home antibiotics, home feedings, home O2. When I go out to make house calls, and yes, I do make house calls, I go out, now usually I'm looking for street numbers, ramps in front of the house, and oxygen signs. And of course, a few year or so ago, I was driving down a street with no street numbers, and there are two houses side by side. They both have a ramp and they both have an oxygen sign, and of course I went to the wrong house. And I knocked on the door and said, I'm Dr. Phelps, I'm with palliative care, and inevitably they said, what is that? And I told them, and they said, oh, great. And I said, oh, so you're Mrs. Smith? And they said, oh, no, they live next door. They're good friends of ours. Go see them and then come back here. So when you're starting to think about those sorts of things, decline in function. We used to talk about patients having the dwindles. It was little old people that were getting weaker, they were falling more, they were losing weight. The technical term now is geriatric fragility syndrome. But you could just kind of look at them and go, they're probably, getting towards the end. Going in or out of ICU. When I was with UT Medical Center in Knoxville, there was a mandatory requirement for patients getting CRRT that they would get a mandatory palliative care consult. They were trying to expand that to ICU. Starting dialysis, unless it's emergent, is a reason to think about it. We get a fair number of patients in hospice that come to us stopping dialysis, not because of anything except they just, the usual thing is, I thought dialysis would save my life. I didn't realize dialysis would be my life. Contemplating a PEG tube. Now, if you have cancer in your throat, which my mother actually did, and you can't get food from here to here, a PEG tube can be a life-saving thing. But if you've gotten so demented you've forgotten what food is, and you don't remember how to swallow, a PEG tube is not the answer. We have in our palliative care what we call the PEG tube death spiral, and it is the single biggest risk factor for getting a PEG tube in the hospital is presence of a full-time speech pathologist that you're trying to keep busy. The scenario goes like this. The nurse gets tired of trying to feed the demented patient. It can take an hour. The demented patients frequently don't want to eat because they've forgotten what it is. And so she suggests maybe a speech consult to see if the patient's aspirating. Speech consult's done, patients over 80, chances of aspiration are essentially 110%. So then GI doctors consulted to put a PEG tube in to reduce aspiration, improve nutrition, and wound healing, none of which actually generally happens. So the patient gets the tube, they promptly go back to the nursing home, pull it out, they come back, they get it put back in, then they get the food pumped in them, it ends up in their lungs, they get pneumonia, they bounce back and forth to the hospital until finally somebody says, this is not working. And they have the conversation. Other reasons to think about palliative care are pain and symptom control, and I'll be talking at some length about pain, or goals of care. The default in most hospitals is, particularly coming in the middle of the night, is for the patient to be asked, by the way, if your heart stops, do you want us to restart it? Yeah, okay, check, we're good. as opposed to a longer, thoughtful, sometimes an hour-long conversation that I wouldn't want to have at 2 in the morning. Now, some of this is because we don't really understand prognosis. Good book called Death Foretold by Nicholas Christakis that talks about how little we learn about prognosis. This was a number of years ago. I haven't seen it improve much. And so he came up with the unofficial physician norms where if you have a prognosis, keep it to yourself unless asked. I can tell you additional research shows that most patients, when they ask, 65% of the time the physician refuses to give them a prognosis. And if asked and you're willing to give it, don't be specific, don't be extreme, be optimistic. The average physician overestimates patients' life expectancy by somewhere between 2 and 5-fold. So it says something about our shared collective humanity that the longer we've known a patient and the more we like them, the worse we get at giving them a prognosis. So what's it all about? We are all perfectly unprepared for something that's totally predictable. Everybody's going to die. How many people here, by a show of hands, have an advanced care plan written up and communicated with their family and/or doctor? A few hands. Okay. You can go to the website honoringchoicestn.org or endoflifecaretn.org. Both of them have it. You can print off an advanced care plan. You do not need a lawyer. You do not need a notary. You get 2 friends to witness it. I had surgery here at Erlanger 3 months ago, and the last thing I did was go to my nurse and say, here's my advanced care plan. I want to update it. I want you guys to sign it. And they did, and they said, are you expecting things to go badly? And I said, nope, just trying to be prepared. So patients actually don't mind talking about this. This is from the California Healthcare Foundation, and they surveyed would like to talk to doctor about end-of-life wishes. It was 95% would like to talk to their doctor. Ever had a doctor ask about end-of-life wishes? 92% said no. 70 to 90% of patients say they would like to die at home. Only about 30% do. 66% say they would like to die a natural and peaceful death, and only 7% of patients desire all invasive therapeutic options deployed that do everything. So I'm going to talk a little bit about communication. It was 20 years after I graduated from medical school before the ACGME came up with the 6 core competencies of physicians. So you'll forgive me if I'm not totally up to speed on it, but communication was one of them. Unfortunately, we kind of stink at that. So this is a doctor saying, I'm sending you to someone who's less squeamish to explain your diagnosis. Doctor comes from the Latin to teach, and 70% of serious adverse outcomes come from poor communication. A couple of statistics from the New York Times: 2 out of 3 patients discharged from the hospital don't know their diagnosis. When I was at UT, we actually went out and interviewed patients to test this theory and found out that that was indeed correct. 60% of the patients misunderstood their instructions. Physicians only introduce themselves 1/4 of the time, and doctors wait an average of 18 seconds before interrupting a patient. So we are lousy at communication. Now, I have to admit, I'm as OCD as anybody, and if I tell a patient, what brings you here? And they say, well, it hurts right here. The reflex is to immediately say, oh, does it bother you when you move? And so I will sit and literally count sometimes in my head to go longer than 18 seconds to keep myself out of that group. What do the patients worry about? This is a survey by the Center for the Advancement of Palliative Care. Patients' concerns: cost, communication, control, choice, cure. And they found that the physicians were not providing all treatment options. Physicians were not sharing information with each other. They were not choosing the best option for the seriously ill. This is kind of to the man with a hammer, every problem is a nail. The patient and family left the physician office without knowing what they're supposed to do 51% of the time, more than half. When I was the medical director for a hospital, I had a family come in and say that the doctor never comes to a complete stop. In fact, they joked they should bank the wall next to their mother's bed because he kind of comes in, keeps stalking labs and whatnot, pats her on the shoulder, and out he goes again without coming to a stop. And I said, does he wear a long white coat? And they said, yeah. And I said, grab it, he'll stop. He did. He came to share his feelings about my intervention with me the following week. They were not positive. He said, I was in there about an hour, and I said, well, maybe that's how long it took to effectively communicate with the patient. He said, but the only thing I have to sell is my time. And I said, well. So you may have seen this down in Renaissance Park, Hospice of Chattanooga, one of the TV stations, and us sponsored it. It was the Before I Die wall. This is international artwork that was actually started by a lady in Louisiana. There was a house across from her in New Orleans that had been plywooded over, and her friend of hers died, and she was thinking about death and thinking about dying, and she went over and painted it with blackboard paint and stenciled on just what you see here, and figured, oh, it'll probably have gang tags all over it when I come back tomorrow. But she put out chalk that people could write, and when she came back, it was completely filled in, no gang tags. And so she took a picture, washed it off, and she did this literally for months, because this is something that people, when you actually ask them about and talk about, have things they want to say and things they want to do. But it sounds kind of morbid to bring it up. You're just kind of out of the blue, so this is an opportunity to have the conversation. Can anybody tell me who these three women are and what they might have in common? Oh, come on, guess. I see a hand back there.
One of them was Karen Quinlan.
Yep, the middle one. I did it in alphabetical order. Nancy Cruzan, Karen Ann Quinlan, Terry Schiavo. I need to add Brittany Maynard. The point is you don't have to be old to die. All of these women made case law. One or two have made it at the Supreme Court over the fact how they were going to die and whether they were going to die. So talking about advanced care planning, this is an ongoing conversation because your goals change, your life changes. First time, young and healthy, that would be most of the residents and medical students here. Express your wishes about how you want to see your life in its final phases. You can write and I'm not a lawyer, but I am told by a lawyer in Tennessee, a holographic will, meaning one written in your handwriting and signed by you, is legal with no other intervention. Talk with your family. Tell them what's important to you. How do you want to live? Do it again when you get to 55 or encounter serious illness because your goals change. When I was 28, I wanted to climb the 7 summits. Never made it to any of them. Now it just looks like a phenomenal amount of work for very little gain, so I took that one off my bucket list. And then again, when encountering a likely life-ending or life-threatening illness and reviewing your choice of preferences. And the goal in advanced care planning is, how do you want to live? It's not about dying. What are your goals? How do you want to live? Paint me a picture of how you see your life. What's important to you? Well, how do you want to be remembered? Begin with the end in mind. It's the conversation with your family, and we have opportunities coming up. There is Thanksgiving, which in the hospice community is called Talk Turkey Day. It's an opportunity. Your family are there, possibly your friends are there, good food, perhaps some adult beverages. This is a wonderful time to say, hey, if I ever got whatever was most recently on the news, then I wouldn't want to be on a machine. I wouldn't want to be on fluids or whatever. We also have National Advanced Care Decisions Day, which is April 16th. You may catch the connection, death and taxes. But any time is a good time to have the conversation if you've got a teaching moment to tell people what you want in your life. Because I'll ask the same question here. I don't expect any hands. So how many people here want to spend the last year of their life being tube fed while the person you love the most wipes your backside? And once again, nobody wants that. But if you don't plan for something that is totally predictable, that's how you end up with it. If you don't do the paperwork, you don't have the conversation. Begin with the end in mind. I had a Sunday school class I taught one time, and I didn't have a lesson brought with me, and so I came in and I turned to the students. It was a high school class, and I said, congratulations, you're all dead. I want you to write your obituary. And they were like, huh? I said, how do you want to spend your life? What's important to you? How do you want to be remembered? So that's where Stephen Covey's Begin with the End in Mind. I had one student that came back to me years later and said she'd kept that in her purse for years and years. She went to college, she went to seminary. She's now an Episcopal priest in Louisiana. I don't know if she still got it, but she said that was kind of how I kept, when things were going badly, how I kept focus. So end-of-life discussions. When do we talk about this? This was a study in JAMA a few years ago. 332 patients with stage 4 cancer. Their life expectancy was about 4.4 months when they averaged them all up, and they were asked the question, if you and your doctor discussed any particular wishes you would have about the care you would receive if you were dying, not knowing that they were dying. 37% of the patients had had that conversation. The other 63% had not. When they went back to the doctors and said, why not? They said, well, we didn't want them to lose hope. We didn't want to cause depression. They actually baked in the Hearth Hope Index and some depression scores, and what they found was that really didn't happen. The patients didn't get depressed. They didn't lose hope. They hoped for different things. And but the significant point was, if they'd had the conversation and they knew that they had a life-ending illness, they went to the ICU a lot less. They went on the ventilator a lot less. And the families did not suffer PTSD from seeing their loved one die miserably. So, how to not to tell patients bad news. I Googled patients, doctors in cancer in the New York Times cartoon website. I got 1,000 hits. So the good news is there are not 1,000 cartoons, but this one's hop, jig, dance, prance. Oh, I've got cancer. This is the procedure for a hospice and palliative care specialist. It's the goals of care discussion. There's two ways to learn. There's skills and knowledge. Knowledge, you can read a book, and if you're really good at it, you can be as proficient as anybody else on the planet. Skills is something you gotta practice to do. And the thing I learned in my fellowship was how to do this and how to have the conversation with a patient without freaking out, without going into jargon, without crying, either them or me. And so this is kind of a quick layout of how to do it. Semiotics is the study of meaning, so what you do says a lot more than what we say. Making an appointment with the patient, setting aside a conference room if available, muting beepers, cell phones, sitting down. Patients double the estimate of how long you spend if you just sit down. Introductions, we would get everybody. I'm going to say for the purposes of this conversation that the patient has stage 4 lung cancer. They're not really completely with it, so I'm meeting with the family. We'll go in, we try to get the nurse on the floor. If we can, we get the physician that's caring for the patient, and we'll sit down and we'll have the goals of care discussion. We'll go around and we'll do introductions, and I'll start by saying, I'm Dr. Phelps. We're here to talk about your dad. This conversation may take as long as an hour or more, so feel free that we've got time. And tell me who you are and what your relationship with the patient is. And they'll go around the room, and I'll tell the patients and families, if he's got a fishing buddy of 50 years, and you're okay with us talking about his health, bring him. Whoever the significant people are, doesn't have to be blood relatives. We're here to talk about your dad. Tell me a little bit about him. Well, he's got stage 4 lung cancer. Tell me a little bit about him as a dad. What does he like to do? What are his hobbies? What kind of work did he do? And I'm not just making chit chat. That is to get the family thinking about the patient and his goals and wishes. What do you understand about the diagnosis? It is amazing the number of people who do not understand the diagnosis. They'll either not understand at all. Remember, I said 60% of patients leave the hospital without knowing what they had. I've had one patient say, well, they say Dad's got a neoplasm in his thorax, but thank God he doesn't have lung cancer. To which, unfortunately, I replied, but that is lung cancer. And then they started crying. So it is important to know where you're starting, and then fire a warning shot. I wish I had something better to say. I wish we didn't have to have this conversation, something along that lines. And then explain the diagnosis. Use small words. If you use adenocarcinoma of the pancreatic head, it went right past them. And then the really hard part, because you just dropped the bomb, maybe tears, maybe anger. I've been threatened with malpractice suits at this point several times. The hard part is to stop, await reaction, validate their emotions, and not do anything. Because what you really want to do is blow through the rest of it and say, well, it looks like he's got a mass on his chest. We're going to get him with an oncologist. I'm sure everything's going to be fine. Get up and run out of the room. But let them vent. Sometimes it's, yeah, I thought so. As I mentioned, I've been threatened with several malpractice suits, and I take that off the table by saying, I can understand you're angry, I can understand you're upset. If you have to sue me, we'll do that later. But today, right now, we need to go forward. Knock wood, so far, cooler heads eventually prevail. Keep the focus on the patient. What does the patient want? Did he ever talk about what he would want in a circumstance like this? Now, remember, you're looking to the family for substituted judgment. So I've had families pounding the desk going, I want for my dad. And I say, I understand you want the best for your dad. You want your dad to live forever. But these are the circumstances that are going to take his life. So in that context, if he could walk in and lean over your shoulder, what would he be telling you? Because that's what you're supposed to be telling me. We talk about CPR. I like the Georgia Post form better because it says allow natural death or do not attempt resuscitation or do attempt resuscitation. Going back to the hospitalist admitting somebody at 2 a.m. and saying, hey, if your heart stops, do you want us to restart it? Yeah. If you change that around just a little bit, and there's a whole science of what they call choice architecture, and tell the patient, hey, you've got stage 4 lung cancer, things are not looking real good. If the time comes while you're here, do you want us to allow a natural, peaceful death? Most patients will say yes. So it's how you ask the question, it's how you phrase the context. When I talk about CPR, I am really graphic. I talk about bones crunching under my hands and how the electricity feels when you shock people. And my intent is patients see CPR on TV, and there it's the sweet young thing's gotten had a heart attack, and and they come in and she codes, and they do defibrillator, and they say clear, and they go, and then she's reunited with her love in the next scene. Somebody actually did research in the New England Journal of Medicine, found on TV the likelihood of surviving resuscitation was between 65 and 100%. In real life, we know it's considerably lower than that. So when patients say they want CPR, I describe in detail what they're asking for and say, now, is this what you want to do to your dad? And by the way, he's got metastatic lung cancer, so if I get him back, he's the 1 or 2% we get back, he's going to have to die again. And that will usually kind of bring people around. Occasionally it doesn't. They say, yeah, we want that. And I'm like, oh, okay. Summarize and record. You want to note who you talk to, because inevitably the dreaded child from California will hop the red eye, come over and make your life a living hell the following day. And it is nice to know, for your partner to know particularly, that that's not who you talk to, so that you can redirect them back to the family. But it is important that we have these conversations because people want to share at the end of life. Memories, wisdoms, keepsakes, connect with loved ones, make some lasting contribution to the world. The philosopher Kierkegaard one time said, life has to be lived from front to back, but only understood from back to front. So we need to give patients the opportunity to have these conversations and to talk. Why don't we? Doctors say, I believe, patients will have difficulty discussing death. Let me say that the farther away from death you are, the easier it is to have this conversation. When I'm making home visits, I usually say, oh, this is great. There's no pressure. We can just talk about it, and and it's down the road. Of course, if I'm talking to them, it's probably not that far down the road, but it takes the pressure off. I have difficulty discussing death. I'm not sure what to discuss or document. I don't have the time. I don't get reimbursed. So here's how to get paid for it. These are new CPT codes as of either last January or the January before. It got held up by the ever popular death panels discussion. You can, if you're in the room talking to the patient for at least 16 minutes and you do the following documentation, you can charge a $99497. And if you go longer than half an hour, you can add on additional charges to that. What do? Time in, time out. Person designated to make healthcare decisions, who participated in the conversation, what was discussed, and what documentation was or was not done. You don't have to do the paperwork. You just have to discuss the thing, and you can do this day after day after day if you want. I expect at some point you'll get a nasty letter from CMS, but right now they haven't defined how many days that is. Oops, I don't know how that got in there again. I'm going to talk a little bit about activity. Unless you're a plant, if you're not walking and talking and eating, you're dying. So we use... I don't have a pointer. We start on the left. Hopefully everybody in here is 100%. And then we look at how well they're ambulating. That's the best sign. And then we look at the activity and evidence of disease and how much they're able to do. Then we look at their self-care, and we go down and over. We never go back up. And so most patients, when they come to hospice, are in the, except with cancer, sometimes they're in the 70s, but most of them are in the 50 to 40, but the vast majority are in the 30%, which is they're pretty much bedbound, unable to do activity, they're total care, and may have normal intake and normal cognition. But this has implications. Remember I said 40 to 50%, now see if I can back up. 40 to 50% of those patients are dead in 6 months. So what's a 50% patient doing? Mainly sitting and lying. They need assistance. They're eating normally, and they're unable to do much in the way of work. If you get down to a PPS of 10%, which was basically mouth care, your life expectancy is usually in a day or so. When I get a report from a nurse, I'm looking at it the next morning, the first thing I do is look to see if the patient's still with us, because the odds are good that they're not. I like this score better. It's from the oncologist, specifically about oncology, because it's only 6 digits, 0 to 5. The only benefit for 5 is I can have a conversation with one of my staff in the mall, and they say, how's Mr. Smith? And I say, his ECOG advanced to 5, and only she and I know that means he died. The real break point is between 2 and 3. 2 is ambulatory, capable of all self-care, but unable to carry out any work activities up and about more than 50% of waking hours. 3 is capable of only limited self-care, confined to bed or chair more than 50% of waking hours. Now that's due to illness. I spend most of my time in the chair, but that's because that's how my work works. But that would make my ECOG score 3. But if you're in the better chair more than 50% of the time because of your illness, your estimated survival is now down to less than 6 months. If you're completely disabled and totally confined to better chair, then you're down to 3 months. So these are just helpful things to look at, but it's not all cancer. Illnesses with a roughly 50% mortality in 5 years include COPD, solid cancers, heart failure, and end-stage renal failure, and I'll touch on these briefly. First, I wanted to say a palliative care study done with patients with non-small cell lung cancer. They got either usual care, including all the oncology they wanted, or usual care, all the oncology they wanted, plus palliative care. And the palliative care arm of the wing had lived 3 months longer. They lived a year as opposed to 9 months. They also got less chemotherapy. They had less pain, less depression, less anxiety. The American Society for Clinical Oncology says after 3 different types of cycles of chemotherapy, goal that you should be really looking more towards palliative care or clinical trials. So prognosis in advanced cancer, malignant hypercalcemia, unless you've got newly diagnosed breast cancer or myeloma. The classic thing is they come in and say, Grandpa's been acting funny. They bring him to the emergency room, his calcium's 12. They do a CT scan to find the tumor, and there it is sitting in the kidney. Chances he'll be dead in 1 month are 50-50. Chances he'll be dead in 2 months are 99.9. Multiple brain metastases without radiation 1 to 2 months, with radiation 3 to 6 months. Malignant fluid, ascites, pleural fluid, you're talking less than 6 months. So these are all helpful things to kind of tell you when you need to be looking at end-of-life preparation. Heart failure. Every time you come into the heart failure, your chances of dying go up 300% and your life expectancy goes down by half. So median survival after the first, second, third, fourth hospitalization went from 5 years to 2.4 to 1.4 to 1 to 0.6. We sometimes call practicing to the tail, which is, well, I remember a patient who had heart failure and he came in 15 times and he lived forever. That's the exception, not the rule. But the statistics say this is kind of where we are. So what we look at is maybe when the patient comes back for their second hospitalization for heart failure, that we start having that conversation. When I was at UT, we were looking at putting into the computer. The first time they came in for heart failure, they got education. Second time they came in, they got home health and maybe telemonitoring. The third time was an automatic palliative care consult, and the fourth time would be a hospice consult, because that's kind of the progression that we're looking at. But patients with heart failure and COPD follow this kind of up and down sort of progress where they'll be okay, then they'll crash, and then they'll get back, but not all the way, and then they'll crash again. So when you think about hospice, the best palliative care for CHF patients is good care. But when they are up to New York Heart Association Class 4, they don't have to have an ejection fraction 20% or less. But if they do, that's a really bad sign. They've had refractory arrhythmias, cardiac arrest. They should not be candidates for revascularization, transplant, or LVAD. You would think, well, yeah, how would you get to hospice that way? I actually had a hospice patient just casually mention he was going to Vanderbilt to look at a lung transplant the next day, and I almost had a stroke. End-stage renal disease, usually a creatinine of greater than 6 if they've got diabetes, or greater than 8 if they don't, and an EGFR of 15 with diabetes or 10 without. And then they will usually have either cachexia, hyperkalemia, oliguria, etc. Now, we talk about that we don't have to have the terminal diagnosis. These are guidelines. These are not, well, you don't check off everything, and if all the checks line up, you're good. Because most patients don't have something in isolation. They have heart failure, and they have chronic kidney disease, and they have COPD. So once again, we come back to that, would I be surprised if on these patients? COPD, these are classically little skinny old ladies that are still smoking. They smoke till they get so dyspneic they can't stand it. They put out their cigarette, they put their oxygen on, they get their breath back, and then they reverse the process. It's always kind of scary because sometimes they don't reverse the process. We've had, in the last 2 years, we've had 3 patients have facial burns from lighting up while they were on oxygen. They're usually very thin. They're usually tachypnic, tachycardic. If you could do a pulmonary function test on them, which is challenging, their FEV1 would be 30% or less. Dementia, if they have nothing but dementia, they've got to be pretty darn demented. To qualify only for dementia, you have to be losing speech and locomotion. So you're down in the 7A, 7B, 7C. If they've got other illnesses, we'll sometimes take them if they're up to the point where they're incontinent and they've got heart failure and or they've got chronic kidney disease. So what happens to the elderly? If you have the conversation, most of them will end up in hospice and they don't go to the emergency room that much. If you don't have the conversation, 50% of the patients come to the emergency room in their final month of life. Of those 50%, 75% are admitted, 40% of them end up in the ICU, and 68% die in the hospital, which is where nobody wants to be to die. So I'm going to tell you a word or two about costs. Bobby Jindal, the governor of Louisiana, if you're from Louisiana, I'm sorry, he was going to drop hospice for Medicaid patients. The headline was "Jindal to the Poor, Drop Dead." He put it back the following month, and the reason was it is much more expensive to die in the hospital than it is to die in hospice. Health Affairs, right after this, came up with an article that said by 15 to 30 days, and this goes out to 105 days, cost savings are about $6,000. Now, we don't like to look at people's lives in terms of dollars and cents, but the short answer is the system depends on us looking at this at least in some abstract fashion. And the hospitals are under pressure. 30-day readmission rates. They went down for a while after the Fed started looking at it and penalizing hospitals. It's in Chattanooga, it's beginning to go back up again. They look at readmission for heart failure, pneumonia, COPD, looking at total hips, total knees, and they've started CABG this year. They're also looking at bundling payments, specifically for some hip surgeries and heart failure. So you get an episode of heart failure, the hospital gets one lump sum. That pays the doctors, the rehab, the hospital for that. And if you come back multiple times, that's all for free. The hospital's only going to get the one payment. And the problem is, this is again from Gawande, so 25% of Medicare spending goes to the 5% in their final year of life. Most of that money goes for care in their final months and is of little apparent benefit. We spend a lot of money because we don't have the conversation on patients and we don't really benefit them. So why do hospitals like it? This is a graph from Archives of Internal Medicine, and it shows palliative care interventions at day 7, day 10, and day 15. And what it shows is when patients know they have a life-ending illness, they start making very different choices about the procedures and processes that they are willing to undergo. And so most hospitals, even over 50 beds, have some sort of palliative care service now. Hospitals over 300, essentially all of them have some form of palliative care. Another cartoon. Thank you, Reverend. Your servant has me super excited about croaking. I'm going to talk a little bit about the actual care of patients, and then we'll be done. Suffering. I mentioned we do comfort suffering. 70% of terminal cancer patients suffer pain. Most of it's unnecessary. Patients also have fatigue, shortness of breath, delirium, constipation, nausea, vomiting, dry mouth, depression, spiritual angst. First, I want to say we've heard a lot about the evils of pain clinics. I totally agree with that. I have a certification in addiction medicine. I have seen that up and close. But we have two problems going on. We have the undertreatment of pain and we have an opioid epidemic. You know, we paddle on one side of the canoe for a while, we paddle on the other side of the canoe. Right now we're paddling hard on the right-hand side of the canoe. I will tell you on the next slide, our motto is whatever it takes, and the state opioid maximums do not apply to hospice and palliative care. Dr. Mutter, the state drug czar, who's from Chattanooga, has said to me personally, you people with hospice and palliative care are paranoid. This is not about you. There is no functional limit to how much pain medicine you can give. Now, some patients can get a rare condition called hyperalgesia, which the more pain medicine you give them, the worse pain they get. So you have to think about that. I had a nurse one time call me, the patient was on a pump. I said, they were in really bad pain. I came out and I bumped their pump up, their pain's getting worse. I bumped it up again, their pain got worse. I bumped it up again, their pain got worse. And I said, well, I think the first thing is turn the pump off. And we rotated from morphine to Dilaudid, halved the dose, and the patient did much better. So it's rare, but you at least want to think about it. But pain, I want to particularly press this point, is not a pressor agent. I cannot tell you the number of times that I've been called in to see a patient and they're in the ICU, they're moaning in pain or even screaming in pain, and I'll say, hey, let's give him something for pain. Oh, no, he could die. So, well, presence of a hospice doctor at bedside is not a good prognostic sign. However, let's not have him die in pain. But there are medications to raise blood pressure, and letting somebody suffer because you want to keep their blood pressure up is really not morally justifiable. There's what we call the rule of double effect. It's an ethical principle that says if my goal is honorable and to try to help the patient, but something bad could happen, like they could die, that is morally and legally acceptable. I cannot walk in with a great big syringe and say, I'm going to put you out of your misery, but I can walk in with a syringe of morphine and say, I'm going to get your pain under control, whatever it takes, and that is acceptable. This is our common language. We talk about oral morphine equivalents. Those of you who use the state website to check your patient's opioids will see this at the end. There's a variety of different scales. All of these are kind of sloppy math. The goal is to at least be in the right ballpark. If you give patients twice too much morphine, they will not die from it. If you give them 10 times too much, yeah, they might. So the goal is just to end up in the ballpark. So if there's a slide, and we have moved my slides to this computer, if you want to pull them off, be my guest. But if there's a slide you want to save, this is the one, because it talks about oral morphine. Me pointing at the computer doesn't you no good. Oral morphine at the top is our common language. If you go to parenteral morphine, the dose goes down to a third. Hydromorphone, which is dilaudid, is 4 times more potent than oral morphine. If you get down to IV hydromorphone or sub-Q, that is 20 times more potent than oral morphine. So you want to be able to trade back and forth in here. But whenever you trade, you want to go down on the dose for what they call incomplete cross tolerance. You want to make sure the patient can tolerate it. Now, I've worked in a pain clinic, and I told them I was going to cut the dose a little bit. And they said, "Oh, I can handle it, doc." And I said, "Yeah, but if you can't, I can't fix that. If you go home and take too much, we're done." So always cut the dose down a little bit. I've got the equivalents for oxymorphone, codeine, Demerol, fentanyl, all are on this slide. I mentioned codeine only as I used to have a slide. It was medications to give to patients I don't like, and codeine was on it. It works by being converted to morphine. Why not just give them morphine? Some people don't. About 10% of the U.S. population does not have the enzyme to convert codeine to morphine. And then there are some that have an extra set of the enzymes, and they convert 100% of codeine to morphine. So you're not really sure exactly what the patient's going to get. So why do it? Timing of medications, time to peak onset IV is 10 to 15 minutes. That doesn't mean you won't start feeling it in the first minute or two, but peak is about 10 minutes. And the point here is if it hasn't worked by the time, shortly after it's peaked, it's not gonna. You haven't given enough, so you need to probably give more. So if you give somebody, morphine Q4 hours pure in pain, and that wasn't enough, you just ensured that they're going to continue to hurt, but maybe not quite as bad. Most of these short-acting medicines last 3 to 4 hours, so they should be given routinely and scheduled. We use 3 prescriptions in hospice: long-acting, that's MS-Contin, OxyContin, fentanyl, Opana-ER, methadone; short-acting for breakthrough, and a stimulant bowel laxative. It is essentially malpractice to give somebody an opioid and not give them something to keep their bowels moving. I had a patient now one time, I said, "Oh, he's in terrible pain, I'll give you some morphine." He said, "Oh God, no. They had to dig the stool out of me last time. That hurt worse than this pain does. Don't ever give me morphine." And I said, "Well, your doctor didn't realize they needed to give you a stimulant laxative," and I'll touch on that again. So what do? Start the patient on Q4, short-acting medicine. I don't use hydrocodone because of the Tylenol. I use oxycodone or morphine. Say take 10 milligrams every 4 hours, round the clock, whether you think you need it or not. For the people who are nervous about that, I'll say, if they're breathing less than 8 times a minute, skip that dose. If you can't wake them up, skip that dose. But that's usually not a problem. If they're really elderly, I'll maybe come in at 2.5 or 5. And then every hour, if you need it, you can take an extra dose. Now, I have to intervene for a moment for a cautionary tale. If you find an idiot-proof system, you will find a better idiot. I had a family, I gave them liquid morphine, and I said, give this every 4 hours, and every hour is needed. And they called me back the next day, or I called them and said, how'd it go? And they said, oh, we're really tired. And I said, why? And I said, well, we were up all night. I was getting a bad feeling. And I said, why? And they said, well, we had to give that medicine every hour. And I go, ah. I said, and Mom, the last 5 or 6 hours, we had to roll her over and drip it in her mouth because she wasn't awake. So I immediately assumed that it's my error. So I say, read me what it says on the label. And it says, give every 4 hours regularly and every hour if needed for pain. And I said, whew. I said, I think your pain is treated. You can stop now. So just kind of keep that in mind. But then you tally all the morphine that was taken, and I use 10 milligrams because it makes the math easy. 6 doses every 4 hours, 10 milligrams is 60 milligrams. We'll say they took an extra 6 doses because they were having additional pain. That's 120 milligrams of morphine. You don't have to adjust for cross tolerance because what you're going to give them is MS-Contin, 60 milligrams twice a day. That's 120 milligrams. Their PRN dose will then be 10 to 15% of that. So you'd probably use a 10 milligram short-acting morphine. Adjusting the dose, we don't go by milligrams, we go by percents. If their pain level less than four, spike the ball, do the happy dance, you're good. If they're a 4 to 6, go up 25 to 50%, not milligrams. If they're moderate severe pain, 7 to 10, go up 50 to 100%. So sometimes this will lead to some impressive numbers. I had a patient who was on 30 milligrams of morphine twice a day, and he was snarfing down all the extra he could and is still rating his pain a 10. So we went from, we did the math, and I did the math again, and then I did the math again. And then we put him on 100 milligrams of morphine 3 times a day with 30 milligrams for PRN. Stayed up all night wondering if I'd killed him, called him the next day. He answered the phone. I was like, and he said, this is the first time I woke up that I wasn't moaning in pain when I woke up. Thank you. This means a lot. It's been 9 months of waking up like this. But that's how the paradigm works to do the dosing. If you got somebody who's on 200 milligrams of morphine and you give them 5 more, you're not doing them any good. A couple of perils. First is number needed to treat to reduce their pain by half is 2.6. Number needed to harm is 8. Was the usual harm constipation and other things? Opioids are processed by the kidneys except methadone. If you have a fairly functional patient and you give them opioids, and I'm quoting a pharmacologist now, testosterone levels go to castration levels in just a day or so. So opioids can do that. Respiratory depression, pretty rare. I treat COPD patients who do not have pain with morphine, and they do well. Now, use small doses, but it's amazing. I've had patients who just literally couldn't believe that they felt that much better. Addiction is rare, and the short answer is I tell patients, the families are usually worried, I don't want him to get addicted. And I say, he's dying of lung cancer. There's no trip to the Betty Ford Institute when I'm done. But families, that's a whole other problem. I've had sons steal their dying mother's medication out from under their pillow. It is a challenge. Maybe 2 or 3 times a year we have to kick an addict out of hospice because whatever we send, it's gone the next day. And we'll say, no, really, seriously, we gotta, you've got to measure this out. Sometimes I've gone to patients, we'll cut down the dosage, the frequency, the number of times, increase the number of deliveries. Sometimes you just can't keep them under control. Constipation is going to last as long as you're giving it to them. Nausea is usually pretty transient. Some patients will get real bad sweating. Sedation is usually pretty transient also. Delirium, we all know hyperactive delirium. This is the patient in the nursing home screaming, help me, help me, help me, help me, trying to climb over the bed rails. That is actually better than the hypoactive delirium, which is more common, which is the patient all hospital nurses love because they just lay there. They don't bother anybody, they don't complain, they don't hit the button, they just pee in the bed and everybody's happy. That is a bad sign. If they got that sort of psychomotor retardation, in cancer patients who develop delirium, their 30-day mortality is 83%. And it's scary to the patient, so you want to treat it. The patients who come back from it say, I just remember being scared. These are a variety of things to think about. This includes drugs, sundowning, hypoxia. Sometimes the only reason you see an 80-year-old suddenly starts becoming delirious is they've had a stroke, a heart attack, a pulmonary embolus, they've gotten pneumonia, they're retaining stool, they're retaining urine, they're undernourished, they're underhydrated. So we have a whole bedside protocol, checking the rectum for stool, checking the bladder, pinching their skin, looking to see if they're having pain before we start treating delirium. Subdural hematomas. We get a lot of hospice patients that have AFib and they're on anticoagulants and then they fall down. If they're a high falls risk, we usually will go to aspirin or something else. Non-pharmacologic treatment, keep them oriented, minimize their catheters and other things, get them up and walk them. And then Haldol, 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 more Haldol. Now, I will tell you, nursing homes freak out at the word Haldol. They freak out at any psychotropic medication because starting February of this year, they're getting graded for the number of patients on psychotropics. But Haldol has minimal cardiovascular effects, minimal anticholinergic effects. It comes as a liquid. It comes as a sub-Q shot. You can give it rectally. The maximum dose, and even I've not pulled this one off, is 100 milligrams orally a day. I've never done that. In the elderly, you might start with a small dose and work up, but it can be really, really helpful. I'm going to say a word or two about nausea and vomiting. Since Halloween's coming up, I couldn't resist this slide. Why do people get nauseated? Whole bunch of reasons. It can be vestibular, it can be anticipatory nausea, infection, inflammation, dysmotility, chemoreceptor zone stimulation. The medications we give can make people nauseated. They did a study. They did an intensive workup on half the patients, and the other half the patients they gave my favorite drug, Haldol, to, and they did the same. So it really is, treatment is the best thing. If Haldol doesn't work, go with a prokinetic like Reglan. If a prokinetic doesn't work, try an antikinetic, which is an anticholinergic, which is Levsin. Zofran is oftentimes very helpful. Marinol and sometimes can be helpful. Constipation, the big thing is stimulant laxatives. Do not give patients on opioids fiber. It just tends to form as concrete. Osmotic softeners, Miralax, lactulose, may give you soft stool, but it doesn't push it through. We call that mush with no push. So you really want a stimulant laxative to overcome the opioids that are blocking the colon and get it out. Lubrication, Docusate, yeah, kind of helps. Mineral oil enemas are okay. We taken Fleet's phosphosoda out because it can damage elderly people's kidneys. And you can take frozen Vaseline balls, you roll Vaseline in cool Vaseline into a pill, roll it through powdered sugar and freeze it. That will help lubricate patients. And then the final is our nuclear weapon. That's the smog enema, equal parts sorbitol, milk of magnesia, mineral oil, and glycerin. I've never had one, but I'm told it'll move mountains. Dyspnea. I had a patient, she had lung cancer, her 90-year-old mother was caring for her. I came in and she's really breathing hard. And I said, where's her oxygen? Her mother said, and this is a quote, I don't want her to get addicted to oxygen. I said, too late. And she pulled out the O2 saturation meter that we all have and clipped it on mom's finger and said, see, her oxygen's 97%. So look how hard she's working to do that. I'm paying for the oxygen. I turned on her oxygen concentrator, put it on her and said, don't let her suffer. I mean, yeah, the number's good, but she's having to kill herself to do it. Fans stimulate the trigeminal nerve and can help with breathlessness. Sitting up can help with breathlessness. Opioids can help with it. Ativan can help with the anxiety related to breathlessness. Anxiety and depression. Single best screening question, are you feeling down, depressed, or hopeless most of the time over the last 2 weeks? 100% sensitive. The one we usually use SSRIs, but if time is limited, Ritalin is a wonder drug. 1 to 2 days and patients are a whole lot better in many, many cases. It's pretty safe. I have to admit I swallow hard when I'm treating patients with end-stage cardiovascular disease, but it can work usually 5 milligrams morning and lunch, maybe go to 10 milligrams morning and lunch. But these patients, if it works, which is not always, but frequently, they're up and smiling like day after tomorrow. It is amazing how well they do with it. Anorexia, I call this the wife's complaint. The wife will say, he always ate my cooking, that's how I knew he loved me, make him eat. The only thing that'll work particularly is bursts of dexamethasone. Megase is a female hormone. It increases your risk for DVTs. The studies show you gain a pound of fat. Not really that helpful. I wanted to say a few words about undoctoring, and I will just touch on this to say Atul Gawande, same guy, wrote an article in the New Yorker, says the reason I'm talking about all this is unnecessary care crowds out necessary care, particularly when the necessary care pays less. I'm kind of circling back to that ethics statement. Gawande in his article said in a single year, 25 to 42% of Medicare patients received at least, sorry for my misspelling, one of 26 useless tests and treatments. Millions of people are receiving drugs that don't help them, operations that don't make them better, and scans that test that do nothing beneficial. He got his information from Gilbert Welch's Less Medicine, More Health, which is on my reading list. We talk about pill burden. The average patient coming to hospice is usually on 20 plus medications. Chances of a drug-drug interaction are essentially 100%, somewhere between 8 and 9 drugs. So, when we have patients with a limited life expectancy, we frequently take them off of some of their diabetic medicines, their blood pressure medicines, certainly their cholesterol medicines, certainly their bisphosphonates, because their life expectancy with us is 6 months, and we're treating for 10 years down the road. And patients actually do considerably better off of a lot of these medicines. I've mentioned this website particularly for the residents. It's called thennt.com, and it tells you how many people you have to treat for one patient to get benefit. It's affiliated with Cochrane Reviews, which you know is a non-pharmacology related site. It talks about osteoporosis, number needed to treat if you've not had a fracture, the number needed to treat if you have, how many people you have to treat with statins to avoid a non-fatal MI. And it's really kind of eye-opening because the pharmaceutical industry is spending billions to recruit you, but nobody is providing the counter-narrative for what this stuff doesn't work. So what do we do for failing patients? Honest discussion about where they are. Let's stop telling the public that exercising and eating blueberries will avoid geriatric fragility. Better advanced care planning, delivery of care in the patient's home, and a system that embraces long-term supportive services. food, transportation, and direct personal services are often more important than diabetes management. The world's best healthcare does you no good if you can't get to it. So in the end, answers are not required. If a patient asks you a theological question, don't respond by saying, I'm a doctor, I don't do that, because they may never ask again, because what you've said is, this is science and I don't deal in superstition. And these are the key questions to these patients. When they ask, why is God doing this to me? Answer a question with a question. Show some empathy. I'll say, I don't know. Why do you think God is doing this to you? Tell me a little bit about what your thoughts are here. Compassion comes from the Latin to suffer with. We are all going to go down this road at some point, and we would certainly want to treat the people we're treating as we would want to be treated. So active listening and emotional validation, talking a little bit about their spiritual life. This is the reading list. These are all by doctors. I already mentioned Being Mortal. When Breath Becomes Air was actually written by a neurosurgical resident who died of lung cancer. And one of his biggest frustrations was his oncologist would not tell him what his proposed life expectancy was. And he said, look, if I'm going to live 10 years, I'm going to go back and finish my residency. If I've got 1 year, I'm going to go home and hug my wife till the end. And if I've got a couple years, I'm going to work on a book. So all of these are here. I recommend all of them. Hader Warrick is actually a cardiology fellow at Duke University. So with that, these are resources. I wanted to mention particularly for the residents, if you go to mypcnow.org, there is an application. I wouldn't be up to my tech if I didn't mention, with all things hospice and palliative care. It's called Palliative Care Fast Facts. You can download it to your phone. It is a wonderful place if you need to know like how to dose methadone at 2 in the morning. That's where you can get that information. It's curated, it's got references, it's updated every couple of years. And then for those of you who did not hold your hand up for advanced care planning, honoringchoicestn.org is where you can get that form. And I think with that, hey, Gramps, his deathbed, 1 word or 2. Thank you, I appreciate your time. I am out of time, but I am happy to stay if there are any questions. Wow, I'm good. All right, thank you. Yeah, no, I apologize. Yeah. If you got an email, if you'll